This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Greg Cooper from the Norton Neuroscience Institute in Louisville, Kentucky. I'm speaking today with Gill Livingston from UCL in London about her paper published in the Lancet in July 2024 titled Dementia Prevention, Intervention, and Care, the 2024 report of the Lancet Standing Commission. This is the third report of this commission, which is perhaps best known for reviewing a growing list of modifiable risk factors for dementia. So thank you for joining us today. This is certainly a topic of great interest, and this was a much anticipated paper. Can you begin by giving us the primary take-home message from this paper?
The primary take-home message in prevention is that around nearly half of all dementias are potentially preventable by addressing 14 risk factors, and these can be addressed both through individual action and through changes in policy. And that's a really exciting message because there are many more older people and many more people at risk of developing dementia.
45% is really a pretty amazing number, I think. This is, as I said, the third report of the Lancet Commission. Would you mind telling us just a little bit about the commission itself, how it functions, and the process behind generating a paper like this?
So the Lancet that started it, they commissioned it, as it were, that's why it's called that. And they contacted me, and what they asked me to do is to try to find experts in the field from a range of countries and a range of disciplines, and to put together what we know about dementia, and also to make some new evidence, really, and to try and change the field within dementia. And so I chose experts from around, and then I realized that we were very high income country dominated over the next ones, and tried to include more people from low and middle income countries. We picked the people, and these are people who are experts and who are willing to work. There's a lot of work in it. And we meet for a couple of days. Before it, we discuss what we think will be in it, and we ask everyone to write a bit in a particular topic. And then myself and some of my colleagues in UCL string it all together to make a draft paper. And then over 2 days, we present what we put in. Everyone comments, we take copious notes, and then we rewrite. And one of the big things is which risk factors, because we spent time trying to work out what we were going to do that would be really different. And we wanted to put together risk factors, and to consider risk factors which have the best evidence. When we worked out the risk factors, we try and consider overlap, because risk factors are not randomly distributed. So the person who has hypertension is more likely to be obese and less likely to exercise, and more likely to have diabetes and more likely to have high LDL. So we try and think about commonality, and we address, we change for that. So we have to work out the risk factors, the prevalence, and we do these complex maths, and then we get an artist to draw it for us. And we write about it in a very open way. So this time, for the first time, we've published not only where we got all the figures for and how we came to the conclusions and how strong the evidence is, but the code, so that anyone else can do the same thing.
In this latest version, the number of risk factors went from 12 up to 14, adding vision loss and high LDL cholesterol levels. Can you say just a little bit about those two new risk factors?
I'd like to start with high LDL because it's a bigger risk in terms of the whole population. So it's very common for people to have high LDL in midlife. And when we've been able to look, it's been about 75% of the population have high LDL, which is really quite significant. And if you divide it into midlife and late life, in midlife, there's really very clear evidence that people who have high LDL have a dose-dependent increase in the risk for dementia if it's not corrected. But for those people who have corrected LDL, and that is mainly through statins, they lose that excess risk. It is not as clear that there is a risk in late life. And that might be for a couple of reasons. But one of the reasons that it might be is that it might be quite a long-term risk factor. So if you only develop it when you're 80, it doesn't make much odds. But if you develop it when you're 45, it makes a huge difference. So it might be that it's the same, it's length of the rest of your life. Or it might be that it's biologically different to have a high LDL in late life compared to early life. So that's LDL, and that's really interesting and relatively easy to address. And the sort of excess risk is about an increased risk of dementia of about a third. And if we look at it in population terms, it probably accounts for about 7% of dementias, bearing in mind that people who have high LDL quite often have other things. I want to move on to vision loss. We didn't even consider vision loss in earlier commissions. So as commissions come, we consider more and more risk factors. And again, there's clear and hopeful evidence that people who have, for whatever reason, impaired vision are more likely to develop dementia. So people who have vision that long-sightedness, or people who have cataracts. But again, those people who have their vision corrected lose that excess risk. And if you look at in world terms, it seems that 12 or 13% of people aged over 50 have uncorrected vision. And I've been quite surprised to find, because it's not my field vision, that people often don't notice. I'm not surprised that people don't notice that they can't hear, because it's sort of famous that people think they can hear and other people mumble. But people don't realise they can't see, because they don't know what anyone else in the room sees. And it's gradual, and often that they just don't know. So even people can have uncorrected vision and be unaware of it.
The vision loss joins a previously identified risk factor of hearing loss, which is very interesting, I think. Do we have a good idea mechanistically why hearing and vision loss may lead to or be a risk factor for dementia?
I think we've probably got more idea of hearing loss because we've been thinking about it for longer. And when we first talked about it, a lot of people said that hearing loss is just an early sign of dementia, but that seems clearly not to be the case, because there are systematic reviews which show that people who use hearing aids are protected. Now, that might be partly that the people who use hearing aids are people who look after their health, but not just it might be a marker rather than just a cause, but it wouldn't be expected to make a difference if it was just an early sign of dementia. It wouldn't make any odds what you did. So it doesn't seem to be that. And clearly the most obvious thing is that when the easiest way to be cognitively stimulated is to hear, and you and I are talking to each other and we're responding to each other, and we have to think. And people who can't hear tend to be less cognitively stimulated. They also tend to avoid gatherings because it's embarrassing and not rewarding to hear. So they often become socially isolated, and they often become depressed. It may also be, I'm not clear about this, but we think it may also be that people who can't hear become less good at looking after their health. They don't, they go to the doctor, and people who go to the doctors miss quite a lot of what's said, but they probably miss quite a lot more. So recently with colleagues, my colleague Sergei Costa-Frida and some other people, we've just published an analysis, a systematic review that looks at all the papers that consider that given biomarkers of the link between loss of hearing and cognitive function. And people who lose their hearing seem to have an increase in tau, but not in amyloid. And they also have increased grey matter and medial temporal atrophy, which is what you often find in dementias, and particularly in Alzheimer's disease. And that atrophy is partly in the auditory cortex, but it spreads further than the auditory cortex. So we think that probably what happens is a lack of stimulation leads to a decrease in the size of your brain, really leads to brain atrophy, and people then have to have two biological changes, increase in tau and MTA, and are more likely to develop dementia.
You touched on this, I think, when you talked about the makeup of the commission. But let me ask, do these findings from this report apply well to both high-income and low-middle-income countries, and even beyond that, across ethnic groups? Do we have information about that?
Yeah, we do. And it's very interesting. So what we tried to do for the relative risk is look at systematic reviews and meta-analysis. We looked at the world literature. But the world literature is in itself very biased. It's 80% in high-income countries, despite the fact that there are more people, majority population are in low and middle-income countries. So while we're giving a picture of the world, that doesn't mean it's the same in individual countries. And I've worked with colleagues since, and so have other people in South America and in New Zealand and Australia, for example. And it isn't the same. And it's very interesting. So probably unsurprisingly, there is more risk in Maori in New Zealand than there are in the white groups in New Zealand. And there is more risk in First Nation in Australia than there are in the white people in Australia. So different ethnic groups have higher burden of risks. And if you flip that round, it means that they also have higher potential for prevention. And then if we look between nations, for example, the South American nations have higher potentially preventable, just in general, but they're preventable risk. And also the individual risk factors may differ between countries and ethnic groups. So social isolation, which can be quite a large thing in USA and UK, is actually relatively rare in India and South America because of the culture that people have. So we're giving a world view, but we have been publishing, and other people have been publishing, views which consider individual countries, and you want individual countries to think about what's most important to them and their population within the country, their different ethnic groups within the country, to think about tackling them.
Paper also describes multi-component dementia prevention studies, which is an area of particular interest to me. Do you mind giving a high-level overview of the current state of the field in those studies?
In general, they have improved cognition, but not very much. Mm-hmm. As you know, randomized controlled trials always recruit participants who consent. And they tend to be more highly educated people and who are at less risk of dementia. And therefore you see less change, particularly over a small amount of time, because when they recruit them, they're cognitively intact. So there is a change, but it's not. There's a Cochrane review which shows it's quite small. It's important in population terms. It should save money, but it's not huge. Interestingly, more recent studies are showing a bigger change. And I think that that's because people are trying to concentrate and more on people who are high risk and recruit more people who are high risk. I think that initially nobody really thought of that. They just thought reasonably we're doing fantastically well if we recruit people to this trial. They didn't consider that. But also I think people are beginning to think about what makes people change their behavior. Because, just telling people to change their behavior usually has no effect whatsoever. So they have to think about what makes people change a large variety of behaviors. And also the other thing that's changing is the initial ones, well, they're multi-component. They were basically entirely cardiovascular. And now they're beginning to move out and think about some more risk factors that you might be able to change.
That sounds overall very hopeful that studies are showing there's real clinical utility to this. If we can identify and really modify these risk factors, we'll see the outcomes that we want. Am I overstating that?
I think we'd like there to be more of a change and it to be scalable and to be something which reaches the people who really need them. I think that highly educated people are probably reading quite a bit about dementia and they've got their Fitbit or equivalents on and they're trying to constantly think, most of them, about ways of keeping themselves relatively well. So I think that we'd like to think about ways that are more scalable and clearly there's a big change in the way that we can get technology Probably technology plus humans, because if you leave people just with technology, they also tend not to do anything. But technology plus humans means that you might be able to get things that are more scalable and be more aware, thinking about how you can develop things that will appeal to and be understood and change the behavior of people who might be less highly educated than the people who develop them.
Now, I think it could be argued that some of these efforts ultimately are aimed at building cognitive reserve, which was discussed in the paper. I guess, first of all, can you say if I'm correct or incorrect and maybe talk a little bit about that?
I think there's quite a lot about increasing cognitive reserve, but there's also things about decreasing damage as well. It's both of them together. But yes, a lot of it is cognitive reserve. So basically, it's the ability to withstand neuropathology without developing dementia. And most people don't much mind what's happening in their brain. They mind how they function and think and feel. And it's very interestingly, a recent postmortem study, which is quoted in the commission, found that there really wasn't any difference in the neuropathology in the brain in populations with a decrease in dementia, but there was an increase in what they would say the cognitive reserve. So we can't prevent your laying down of amyloid and plaques, then perhaps we can make our ability to withstand it. So I think a lot of these things, the idea of being cognitively, socially and physically active is to increase your cognitive reserve and make you able to withstand. But I would suggest, and I think that all doctors in the world would suggest, that it might be a good idea not to smoke, say, and actually damage your brain.
Right. So ideally prevent the pathology and build up as much reserve to any pathology that we still unfortunately get.
Yeah.
Yeah.
That's right.
So in addition to the 14 risk factors that were identified, I might say there are some risk factors that are on a watch list, if you will. Do you want to say anything about that?
I'd like to say, first of all, I'm not very good at predicting what will get the most evidence over the years in between. I always have ideas in my head, and I can't say that I've been all that good at it. But there are quite a lot of things that we're not saying they're not a risk, but we're not sure they're a risk. So there's not got enough evidence. So I think in general, the ones that other people, not me, think are the most important are sleep and food. We've just published a systematic review in which we've looked at short sleep, and we've divided it for the first time into short sleep, which precedes dementia by more than 10 years and that which precedes it by less than 10 years, because we want to try and tease out reverse causation. We know that as people develop dementia, they're not as good at sleeping. And that was more than 10 years. That wasn't significantly related to sleep. However, there was quite a lot of heterogeneity. So studies showed different things and we couldn't work out. We tried to do various techniques to find out what was causing it, but we couldn't. So I certainly think it's not proved. It's definitely the case that as you're developing dementia, your sleep gets less good. And that's reverse causation. Whether having less sleep causes dementia, if you have it in midlife, I think it's really unclear. Sort of moving on to food, individual studies of vitamins have shown that they don't appear to make a difference. If you have a normal diet, I mean, it's different if you're vitamin deficient. If you're normal diet, individual studies have shown that that doesn't make a difference. And I think that diet is just very, very complex. It's long term. It has lots of components and it's very complex to tease out answers. It's quite easy to work out if it's one vitamin, but quite different if it's a diet. Clearly doesn't do any harm to have a better diet, and obesity is related to hypertension and diabetes, which are definitely risks. So something that I think might be, but I might be wrong, is infection, and a protection might be vaccination. Again, it's difficult to work out. It's people who have vaccinations have better health behaviours, look after themselves better, and usually have more money and more ability to look after things. But it does seem that people who have infections of a severity which get them into hospital are more likely to have a vascular dementia in particular. So it's just difficult to know if it's confounding factors. And also it seems that it's clear that if people have brain infections, but I'm talking about global infections rather than brain infections. And it seems that people who have vaccinations which prevent severe infections are less likely to develop dementia. Again, I'm not absolutely sure what the cause of that is. So I'm thinking about infections myself as being quite likely, but I don't know. When we go into the room and present the evidence and people add to evidence, it's frequently not what I thought the year before.
How can we apply these findings to individual practice? And I think as a corollary of that, you may have already answered this. Do we have evidence that doing so can help us realize this reduction in the risk of dementia?
I think that's one of the most exciting things. In the last few years, we've had more and more evidence that it can. And some of that's randomized controlled evidence. So hypertension, every time there's a trial of antihypertensives, they tend to be abandoned because the control group does so much worse in terms of cardiovascular health. But if you put them all together, it's quite clear that treating hypertension reduces cognitive impairment and reduces dementia. So that's one thing. Similarly, although it wouldn't be ethical to have long-term trials of statins, there's been sort of emulation trials where people are matched as if they were in a trial. And it does really seem to make a difference in midlife. So I think that these things seem really fairly clear. Diabetes and obesity, which are very linked. Interestingly, the new GLP drugs, which have been given for diabetes and more recently are given for obesity, in the trials for diabetes, in the randomized controlled trials, people on them were less likely to develop dementia and less likely to become cognitively impaired. And these were randomized controlled trials, so that's excellent evidence. We don't know yet whether people who take them for obesity who don't have diabetes are also protected. So we don't know that, but there is evidence that treating diabetes makes a difference, treating hypertension. There was a recent study from Johns Hopkins in the States, from Frank Lim, on a randomized controlled trial of hearing aids. And that was very interesting because they had two groups in it. It was a pre-specified analysis. So one group were people that they advertised with, and the other group came from a cohort study who were older and sicker. And the people that they analysed, there was no difference in using hearing aids. The people that they advertised for, and that group were, one of the reasons why there was no difference is because the group who were much healthier than most people, and they didn't deteriorate at all. So there was no possibility. But for the group that had a variety of other problems, they and were older and were more likely to smoke and be socially isolated, there was a massive difference in using hearing aids in the randomized controlled trial. So again, it's about perhaps the people who really need it, getting to them. So I think these are quite a few things. Again, in cohorts, not trials, they're vision corrected, do better. So I think there's really quite a lot that we can do on individual practice, sort of doctory things about illnesses, hearing, vision, decreased smoking and alcohol in cohort studies. Even after a couple of years, people who weren't cognitively impaired and who drink too much, they lose their excess risk. So I think there's quite a lot that we can do. There's also a lot that can be done in public health outside our individual control.
I think very encouraging and potentially very exciting. Listen, it's been a great pleasure talking with you today, Dr. Livingston. Thank you so much for joining us on the podcast. Again, it's been our privilege to hear from Gill Livingston from UCL London about her paper published in the Lancet in July 2024 titled Dementia Prevention, Intervention and Care, the 2024 report of the Lancet Standing Commission. Thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.